Assalamu alaikum jami'an. I would like to start by thanking Prof. Hassanin and all the organizing committee for their tremendous work in organizing two meetings. Today I will be presenting to you some new studies and some of the work that we have done on thyroxine intake during Ramadan. These are my disclosures. So the outline, I'm going to try to be focused as much as possible. After going through introduction, we'll talk about the different thyroxine regimens that are acceptable in the non-fasting state, and then we'll focus on the studies that were done in regards to its intake during Ramadan. So as you all know, hypothyroidism is an extremely common disease. It probably comes next to type 2 diabetes. The prevalence worldwide ranges between 2 to 5%, depending on which area. We don't have much population data coming from the Middle East. I did find a couple of papers in Saudi Arabia, but mostly done in local regions and local hospitals with, as you can see, a prevalence that's a very overestimate because of the referral bias between 15 and even 59%. There was a paper that included different areas, and the prevalence there was 18.7%. And probably the best paper I found was including around 10,000 patients coming from Asir region, and it looked into different thyroid disorders in their population. And there they got a prevalence of 5.3%, which is very closer, much closer, to the worldwide prevalence. So the mainstay of management of hypothyroidism is levothyroxine. And levothyroxine development has gone through many stages over the last 100 years, from its first isolation in the 1920s to it becoming the mainstay as monotherapy in the 1970s, and with continuing improved formulation and more reproducible and stable dosing regimen. However, it does remain to be a sensitive drug that is given with very meticulous instructions to be taken on an empty stomach, not to be mixed with food or supplements like calcium, iron, or magnesium, and as much as possible to stay with the same product with no substitution. And this comes from the many factors that can influence thyroxine absorption, starting with factors affecting stomach acidity to factors affecting its intestinal absorption. In addition to that, even whether it's taken evening or morning affects it, having malabsorption status, and of course adherence, since it's a very lifelong medication. So these factors affect or reduce the exposure of the body to thyroxine. And then you have factors that can alter the TSH level and the way that you adjust that medication, starting from pregnancy to different medications to the biorhythm itself, with it being lowest in the midday, and other factors that can affect the TSH assay. So because of all these factors, it has a very meticulous intake. And before we go further, another point that's important to mention is that each patient has his individual set point, and therefore we find the range of TSH being really wide, going from 0.4 to 5. So the set point for different people for optimum functioning of the HPT axis is different. And the recommendations on when to take it is really, if we go through the guidelines so far, based on not much that of strong evidence. So let's go through some of the studies that were done in the non-fasting state. What we know so far is that when it's taken on in the fasting empty stomach, it is the most stable. In this study that included 65 patients, they had patients who took it before breakfast with at least 1 to 2 hours until the time they ate, and then people who took it with breakfast within like half an hour of breakfast, and people who took it at bedtime. And the least variability was found when it was taken on the fasting state. Now, taking that as reference and comparing taking it with breakfast or at bedtime, it was found that the least variability next to that would be when it's taken at bedtime with less than a 1 milliunit difference compared to the fasting. In a randomized trial that included 90 patients, those patients were blindly taken the tablet both in the morning and at bedtime. One of them would be the dummy, another one would be the active hormone, and then they were crossed over. And in this trial, actually, it was found that taking it at bedtime was associated with a better TSH level and more reduction in TSH compared to taking it at morning. The explanation here would be that most of the people taking it in the morning would be taken within half an hour of food. So while most of the people taking it in the evening, it would be at least like 3 or 4 hours after dinner. And in addition to that, you have an overnight of a more prolonged exposure to the drug in the intestine, but maybe that could have contributed to better absorption. However, in another trial that took patients with hypothyroidism initially and then randomized them to either taking evening dose or morning dose, eventually by 24 weeks, more or less, both groups reached equal TSH or control. So since 2014, the ATA guidelines have been recommending both timings as alternatives. So either 60 minutes before breakfast or at bedtime, but condition that that would be 3 or more hours after the last evening meal. And as you can see, it's labeled a weak recommendation with moderate quality evidence. So what about Ramadan? And as you know, things change so much from sleeping hours to meal timing to a very busy life of different religious activities, and fitting the thyroxine intake in that schedule can be challenging. And before we even go into people who have hypothyroidism and take thyroxine, I wanted to ask, is there a pure effect of fasting on TSH levels in patients who are normal or euthyroid individuals? And actually, this has been studied, and there was a paper on 46 volunteers back in 1991 that looked into TSH levels before, during, and after Ramadan. And what was found that fasting per se does have this effect of raising the TSH during Ramadan, but then it goes back to normal after Ramadan. So when is the last or the best time to take thyroxine during Ramadan? And there have been a number of studies done in the Middle East, starting with this study in Pakistan back in 2018 that had a cohort of 64 patients. And they were followed with TSH levels pre and post Ramadan. And it was found that post Ramadan, the TSH level did significantly increase compared to pre-Ramadan. However, it still remained within the normal range. And there was no difference between people who are compliant or non-compliant to the meal instructions and intervals given to them. So conclusion that TSH is not affected by timing our interval from the meal. Another study by Dr. Zainab Dabbous and colleagues in Qatar randomized patients during Ramadan to one of two regimens, either 30 minutes before iftar or 30 minutes before suhoor. And what they found, again, similar to the Pakistan study, is that the TSH level in both groups, pre and post Ramadan, does significantly go up. However, between groups, there was no significant difference. And when they looked into convenience, it was found that more people in the group A or the taking it before iftar group were happier with the regimen than the before sahur group. And in a study from Iraq that divided patients during Ramadan into 3 groups, this was a smaller study that had 50 patients. The groups divided were either to take it pre-sahur, 1 hour before sahur, or pre-iftar, so that's at sunset and wait 30 minutes and then eat, or 2 hours after iftar. And again, they did not find a significant difference between groups in regards to TSH, whether those were controlled or uncontrolled. However, those who were uncontrolled during Ramadan did have less control during Ramadan, and overall the difference between groups was not significant. In a study from the UAE, they looked again into 3 different time points. They had 100 and close to 150 patients, 50 in each group, either before iftar or after iftar or before sahur. And what they found is when dividing the pre-Ramadan TSH into centiles, for those who are in the lower centiles, the 25th and 5th centile, those taking the thyroxine after iftar or before sahur had a more significant rise during Ramadan compared to those who were taking it before iftar, meaning that before iftar might have been a more stable group in this category. And then we have also another interesting study from Egypt that took place over 3 years of Ramadan. So eventually they had a total of 292 patients. However, this was not randomized, and they used either one of 4. So either 60 minutes before iftar or 3-4 hours after iftar, provided that sahur was not to be taken at least 1 hour after that. And the third regimen was before the start of the fast, so before Fajr, but again with the condition that the sahur was at least 3 to 4 hours prior. And then if it was a mixture of 1 and 2, they would have called it regimen 4. And what they found, again, similar to other studies, that TSH in all groups does increase post-Ramadan compared to pre-Ramadan. However, it does remain within the normal range. And the change was much more in those who were non-compliant or non-adherent compared to those who were adherent. Now, this year, there was a publication from Saudi Arabia, from Riyadh, King Saud University, by the group of Dr. Anwar Jammah. And they had patients who had prior thyroidectomy, mainly more than 70% were people with thyroidectomy, post-thyroidectomy for thyroid cancer. They divided them again into 3 time points. So either taking it, the thyroxine 30 minutes before iftar, or 3 hours post-iftar, or 1 hour before sahur. Again, roughly around 150 patients, 50 in each group. And what they found was the TSH significantly increased post-Ramadan in those who took thyroxine post-iftar and pre-sahur, but did not significantly increase in those who took it pre-iftar. However, T4 was comparable between groups, and the between group significance was not there. So now, according to all this, what we have now in the guidelines and what's promoted during our consultation with our patients is to take thyroxine in one of 2 timings. So the more common is that you can take thyroxine after breakfast with a date and sips of water, and then wait 30 minutes and then eat iftar. So this is one. Or you don't eat for 4 hours after iftar, and then you take it, and then you abstain from eating for another hour until you can have suhoor. So we kind of find these kind of recommendations for some patients might be inconvenient. And I would like to quote here from the ATA guidelines that it's important to consider not only when thyroxine absorption is optimal, but also to be aware of what timing promotes adherence, because on the long run, adherence is what's more important and what makes a difference for optimizing the the euthyroid status, and you can always compensate for if the 20 or 30% difference in absorption between having it on with meals or in the fasting state. So we asked the question, and we proposed a different time, and we looked into the effectiveness of giving thyroxine right before Fajr, regardless of what the last meal was, compared to the more common recommendation of taking it at Maghrib with a sip of water and then eating after half an hour. And this study was a multi-center, open-label, randomized trial. It took over in the medical cities of the National Guard Hospital in 3 cities between Riyadh, King Abdulaziz Medical City, Jeddah, King Abdulaziz Medical City and Primary Care, and Al-Hassa, King Abdulaziz Hospital and Primary Care. We included only patients with primary hypothyroidism who are adults and who were on a dose of more than 25 micrograms a day. And we excluded patients with thyroid cancer and pregnancy because in those patients, more tight TSH suppression is needed. So after screening thousands of patients, we ended up with 432 patients who give preliminary acceptance to enter the study and were randomized into either a pre-iftar group or a pre-fajr group. So again, pre-iftar means to take thyroxine with sips of water on a date at time of Maghrib Adhan, and then wait 30 to 60 minutes and then have iftar. And the pre-fajr group were basically to take the thyroxine just before the start of the fast, just before the Fajr Adhan, and regardless of whether they had sahur close or not. And out of the 432 patients, we had a lot of withdrawals and some did not comply on doing the labs post-Ramadan. So eventually a total of 303 patients are what entered the study, 156 in the pre-iftar group and 146 in the pre-fajr group, divided between the 3 major cities, Jeddah, Al-Hassa and Riyadh. There was no significant demographic differences between our groups. Average age around 49 with a predominance female, and average duration of hypothyroidism of around 10 years, and average weekly dose of 750. Now, looking into the TSH and free T4 levels before and after Ramadan in our patient group, we saw similar to what has been shown in previous studies, that whether you look into group A or group B, there was a significant difference in the TSH level post-Ramadan compared to pre-Ramadan, with it rising, but remaining within the normal range. And we also found a mild reduction in free T4 levels post-Ramadan that was significant compared to pre-Ramadan. However, if you look into the distribution between the groups at baseline, there was not significance, and even post-Ramadan between groups was not significant. Whether you look into TSH or T4, although numerically the difference was very minimum for T4, but somehow it did reach statistical significance. Now, looking into change over time, again, there was no significant change, whether we look into group A or group B, and whether we look into TSH or T4, meaning the difference between groups and the change in TSH between groups compared was not significant. So you could see here, so again here within subjects mean difference, whether we look into TSH or T4 was not significant. Another outcome in our study was patient satisfaction with both regimens, and statistically it seems that it was not significantly different, but if by eyeballing, looking numerically, you do find that those who took it pre-Fajr found it a little more easy and less exhausting. But this did not reach statistical significance. So our study conclusions, I would say, it's the largest RCT to date, and we found both regimens associated with significant changes post-Ramadan compared to pre-Ramadan, if we look into the TSH level itself and the T4 level itself. However, it did remain within acceptable lab range, and these differences were not significant when compared between group. Pre-Fajr regimen proved to be convenient and non-inferior to the pre-Iftar regimen, and I think it does serve as an alternative dosing regimen that can be utilized according to patient preferences. So just to round things up, I think in conclusion, I have showed you how L-thyroxine is quite a sensitive drug that is affected by the timing of intake and the fasting status. However, most Ramadan studies, regardless of timing, have shown that there is a rise that happens in TSH post-Ramadan, but it does remain within normal range, and that there isn't much differences between the different regimens that have been studied. And given the lack of significant differences between regimens, I think patient convenience and preference should be a determining factor in choosing the regimen during Ramadan. With that, I would like to acknowledge and thank my research team, my co-investigators, fellows, and research coordinators, and thank you all for listening.